So I'm joined today by Harold Nwaboku, and Harold is a hip and knee surgeon with Total Orthopedics. Good morning, Harold. Thanks for joining us.
Good morning.
And
Good
just
morning, all.
give us a very quick sort of summary of who you are, your background, and what you do there, Harold.
Yeah. Well, I'm Harold Nwaboku, as Rob said. I'm a hip and knee surgeon, and I have a special interest in really all disorders of the hip and knee, particularly the management of osteoarthritis and sports injuries. And I've been doing what I've been doing now for the last 20 years, and really following the plans on management of longevity of joints, trying to really maintain restoration of motion, relief of pain, and allow people to continue to function as much as they can. Of course, the last resort is surgical intervention, but if we can really work to get individuals who are, of course, as you know, are living longer and remaining very active, keeping their native joints.
Great, excellent. So we're going to, as you touched on their osteoarthritis, we're going to touch on, we're going to concentrate on that today, and we're really talking about the cartilage, that what's called the chondral cartilage, which is for anybody watching and doesn't understand, is the white sort of shiny stuff that overlies the bones on joints, and that's prone to wearing out, unfortunately, as time goes on, with wear and tear and sporting activities, and it has limited sort of repair capacity on its own. So Harold, when it comes to things like people would have heard of maybe things out there that have been searching, things like injections that they might be able to have to try and mitigate some wear and tear, things like PRP, even stem cell injections. What's been your experience with those sort of modalities?
The first thing I often will speak with patients and others about is that the cartilage doesn't have a nerve supply or a blood supply or a lymph supply. So that often surprises a lot of individuals when they're told that this doesn't have a nerve supply, because the question they ask is, where's the pain coming from? Then the pain can be coming from the subchondral bone, the bone underneath the cartilage. It can also come from the chemicals released by the lining of the synovial tissue, and that produces chemicals that act as inflammatory mediators and cause pain. So one of the things that we really look at in individuals with cartilage problems is to find ways of managing them. And that includes what we describe as pharmacological and non-pharmacological means. Of course, everyone knows about the non-pharmacological means. They look at diet, they look at weight, they look at lifestyle. And the pharmacological means, the realm of orthobiologics, which has become really a hot topic now. It's the use of pharmacological mediators to help with the management of patients with osteoarthritis. And that's a spectrum from the curcumin of turmeric capsules to the use of the patient's own tissues, whether it's a specimen of their blood spun in a machine called a centrifuge, the use of what we call mesenchymal stem cells, fancy name for what we get from the bone marrow or the adipose tissue. And in the case of the knee, we certainly are very interested in that, because it's a way of maintaining the activity of the individual. The other non-pharmacological that I didn't actually mention was your good selves, osteopaths, physiotherapists, also with real lifestyle information, and looking at the patient and not just the joint. Although I'm a hip and knee surgeon, I have to remember that the patient should be treated as a whole, and that means looking at their spine, looking at their alignment, looking at their hips, looking at their knees and foot and ankle. And often it's a surprise when you find that somebody might have treatment of their hip that helps resolve the pain they're experiencing in their knees.
Excellent, yeah. And as you say, those sort of biomechanical issues and just of influencing the way they transfer weight and the way the weight comes through their knee. Like you say, looking at the above and below the knees is often very important. So you mentioned there in terms of the pain-causing mechanisms, and often how it's not the cartilage itself, but it's the the sequelae of reactions that come from that cartilage damage. So with the orthobiologics, would you say, is it just working in terms of an anti-inflammatory, or does it work beyond that level? So working more than, let's say, a standard kind of anti-inflammatory approach with non-steroidal anti-inflammatory tablets and steroid injections? Is it doing something more than just that, or is it a different way of producing an anti-inflammatory reaction?
That's an interesting question, because in the past, what we managed for patients was, we talked about non-steroidal anti-inflammatories, which is actually going against the idea of the orthobiologics. The anti-inflammatories reduce the inflammatory uh, chemicals such as the prostaglandins, and reduce the inflammatory response to reduce pain. So you'll have the non-steroidal, you'll have steroid. And that counteracts the effect of the orthobiologics of, say, PRP. PRP is pro-inflammatory. And of course, with anti-inflammatories, patients want a quick fix. They want to get out and about, and it works very, very quickly. The idea of orthobiologics is allowing the patient's tissues to heal, and that takes time. The platelet-rich plasma stimulates cytokines. Now, I don't want to become an anorak, but cytokines are interleukins, and they contribute to actually not only reducing the inflammation or the chemicals that produce the inflammatory pain, but help with the regeneration, in quotation marks, which is a healing response to the cartilage. The hyaline cartilage that lines our joints never really recovers. I think you mentioned we have a cartilage-like healing response to help reduce the pain and take the pressure off the subchondral bone.
So that's the fibrocartilage reaction you're talking about.
It's like fibrocartilage, indeed.
Yeah, but it's not going to be as good quality. So no. do you honestly think, though, how that the PRPs and those sort of things have the capacity to, if somebody has got some cartilage degeneration, is it realistic for them to expect for that cartilage degeneration to repair in a wholehearted way with just those injections? Or are you saying it's more a case of you're going to get some limited healing, but perhaps better quality healing than they would otherwise get with just like filling with fibrocartilage? Or what scope of recovery in terms of healing response can they get?
The orthobiological PRP is really hot topic now, and there will be individuals who will quote healing and regeneration, but there's, as far as I'm aware, no scientific evidence to show that it actually fully regenerates. There are small studies, really small sample sizes, that indicate that the joint space, particularly in knee osteoarthritis, gets restored, but the study doesn't indicate whether the image is taken, the X-ray is taken standing. It's one of the ways to try and actually allow individuals to continue their activities. It was started in the elite sports people, the level 1 sports individuals, just to make sure they maintain their career as long as they could. Of course, the problem is that the information given to the patient is really, really crucial. It is a delay tactic. It's allowing the individual to do the things they want to do, because the end stage would be surgery. But the hope is it's not the type of surgery that involves replacing the joint. So we want to try and delay it as long as possible. Their function, exercise, can improve with the use of orthobiologics.
So would it be fair to say then, orthobiologics compared with, let's say, a steroid injection? So somebody could have a steroid injection, and they'll probably get quite a significant, anti-inflammatory response, quite a good reduction in pain. But it's as you say, it's going to be potentially counterproductive for the health of their cartilage. So they might get away with one, but they start having 2s and 3s and multiple steroid injections, and that presumably is just going to accelerate the degradation of their cartilage. Whereas with orthobiologics, you're trying to, in the worst case, not do anything more. You're certainly not going to accelerate it. If anything, you might, in a limited capacity, improve it, but you're not going to, accelerate that degeneration in the same way as the steroid injections would do. Is that a fair thing to say in your opinion?
That's very fair, because all the studies that I've come across now have been comparing orthobiologics, PRP in particular, with steroids, and it's found more favorable results with PRP when compared with steroids at 18 months and 5 years. The effects of steroid, unfortunately, is that steroid can affect not only the cartilage, but the tissues, the connective tissue, the skin, the tendons. Individuals may have steroid injection to allow them to return to their activities, but in the long term, 2, 3, 4, 5 courses of injection of steroid is not beneficial. And you'll find patients may come to you, Rob, and say, look, I've been told that I can't have any more injections, but I've been sent to you. Yeah. And then you're breaking down how to actually manage that individual, because the information that we know regarding steroids, it has long-term effects on soft tissues.
So they tend to get, like you say, in my experience, they tend to get a quick response, and they're happy for maybe a few months, but then things are potentially maybe a little bit worse than they were originally. So, okay, great stuff. So let's move on again. And so let's say somebody's had gone down the orthobiologics route, and they've now started to get maybe it's a few years down the line, and it's a little bit worse than things were, and they've mitigated, they've strung things out a little bit. They're looking to maybe have to look into something different, or let's say their injury itself is more severe, and it's maybe not like what we might call a grade 1 or 2 or even 3 cartilage lesion, but it's like a grade 4, meaning, for those that don't understand, meaning that it's now down to the raw bone. So if it was a crater, you've gone through the complete cartilage lesion, you're now down to bone exposure. Can you give us a quick overview on options for those sorts of individuals?
Well, something I've been really interested in the grade 4, as you say, where the articular cartilage is almost non-existent. When you assess the patient, we're looking at the knee. The alignment of the knee is going to be important, whether there's increased load on one aspect of the knee. You can still consider non-operative measures, which include bracing, looking at their shoe wear, supportive shoes to take the load off the knee. And the age is going to be very important too, because what we want to try and do is delay as long as we can while maintaining their function. Admittedly, I have had patients in their 50s have had to replace their knees because we've exhausted all the other methods of treatment. One of the things that I find really interesting, particularly the individuals who have normal alignment, is a subchondroplasty, which I think we talked briefly about. And the idea about it is, again, the mantra I have is cartilage is avascular, aneural, alymphatic. So the question people will ask, where's the pain coming from? And in some instances, when the patients present and are assessed, the x-rays show degenerative change, but they have pain that just seems to be out of proportion to what you would see on the x-ray. And the next course of planning would be an MRI scan. An MRI scan may show bone marrow edema, which is an area where increased stresses to this, what we call the trabecular bone, which is forgive me if I appear to be simplifying it a lot, but the trabecular bone is under stress. And when it's under stress, you have edema, and the edema increases the pressure within the bone and causes pain. So subchondroplasty I've been doing for the last 3 years now, and I must admit I have been amazed. I can give examples of a 65-year-old who I would have sworn he needed a knee replacement, but he was fearful of losing his job. And the recovery time before return to work would be 2 to 3 months. And I explained other options and went down the route of a subchondroplasty. He had me do a joint degeneration. And touch wood, it's probably 6 to 9 months now. And he wants the other side to undergo a subchondroplasty. He's so pleased with his left knee.
The other side of his knee, or the other joint?
Oh, the other joint. He wants his right knee treated by subchondroplasty. So that's been favorable. And so far, I haven't had anyone complain about pain, which is just tremendous news. Admittedly, it's a small number, but it's something I offer patients.
And sorry, go on, Harold. Yeah.
The ones that look at evidence, because subchondroplasty is probably about 9 to 10 years old.
Yeah.
Some will want a quick fix, and the options available are either an osteotomy to realign the joint, a partial knee replacement, or a total knee replacement. And the results for patients who are in their 60s are very, very good for total knee replacements. And off-the-shelf total knee replacements have a lifespan for between 15 and 20 years, depending on the age of the individual. The younger they are, of course, and more active they are, the shorter the lifespan. Up to 10 years for someone who's 50 and very active.
Okay, excellent. Well, and we'll get into a little bit more detail in a minute on knee replacements, but just to linger a bit more on the subchondroplasty. So just so we can understand exactly, well, not exactly, but get a better idea what we mean by that. So again, correct me if my understanding of this is wrong, but so I understood to be where you have, as you mentioned, that subchondral bone edema. So we're talking about, you've got the cartilage layer, you've got the bone underneath, and the bone underneath is where you've got that little pocket of swelling, and we think that's where the pain's coming from. And am I right in saying what you're doing is you're coming in, and it's is it right? Is it an arthroscopic procedure? But you also then come in with a probe that comes into that point, and it fills that little defect of bone in with essentially a little bit of bone cement. Is that right?
That's absolutely right. It's done under general anesthetic, arthroscopic procedure, because the material we use, called AccuFill, has calcium and phosphate, and it's a support, and also can stimulate the healing response in the subchondral bone. So we use X-ray guidance. The company is Zimmer Biomet. I think they're the main ones that use the AccuFill, and it fills in that space without too much in the way of pressure. And then the arthroscopic procedure is to ensure that the calcium hasn't actually eluted into the knee joint.
Okay. Does it fill anything? Is it just the bone that it's being filled in, or does the original cartilage lesion, does that get plugged at all in any way, or not?
No, it's just the bone.
Okay.
In the grade 4s, where you've got diffuse non-focal arthritis, it's very difficult to put a patch on. And in those instances, I offer them the choice of a subchondroplasty. So what it does, it's almost the same as having a carpet below a carpet.
Right.
So it takes the pressure off the bone itself.
And can you just briefly talk to us about so the subchondroplasty versus things like nanofracture, and where you'd use one versus the other? Perhaps.
In osteoarthritis, I suppose we could describe it as a journey. The nanofracture, which is use of a 0.9 millimeter fine pick to stimulate healing by really going beyond the subchondral bone to get to what we describe as mesenchymal area, is what we do for the local or focal cartilage defects. So let's say, for example, a 25-year-old who has had an injury playing football or basketball, and we've isolated based on their clinical and imaging studies that they've got a focal defect under 2.5 centimeters. And in those instances, we look to see if it's just a focal cartilage defect, then we offer them nanofracture. In the United States, I think they have microfracture, but my experience with microfracture is that a lot of the patients not very pleased with keeping off weight on and being on crutches for anything from 6 to 8 weeks. With a nanofracture, the patients can start fully weight bearing within 2 to 3 weeks.
Okay, that's a big difference. Yeah, I mean, I can talk from a little bit of experience there, having had a microfracture some years ago, and another big repair, which I won't bore you with. But the worst one, I was on crutches for 4 months, and that was nearly sent me mad. So I can definitely relate to that.
Indeed.
That's really fascinating. So in terms of the subchondroplasty and the nanofracture, so again, inclusion criteria being, again, correct me if I'm wrong here, Harold, but with things like the nanofracture, again, the idea is you are trying to aim for a little bit of cartilage filling in, stimulating those bone marrow cells, as you say, to sort of stem cells to come up and fill in a little bit of hyaline-like or chondral-like cartilage as best you can. But I think I'm right in saying the inclusion criteria for that, as you mentioned, is the lesion must be no bigger than 2.5 centimeters, and I'm also right in saying it tends to be done only if there's like a single lesion in the knee. So if you've got pockets, like if it's like a road where you've got one little pocket, fine. If you've got a road but you've got multiple divots and multiple potholes, it becomes a bit more difficult to, almost not really appropriate for nanofracture. Is that right?
It's difficult, but I think I wouldn't rule it out, because examples of sportsmen who have actually had the nanofracture include some of the semi-professional footballers who have localized focal chondral defects, or we can describe potholes, probably the best way to look at it. So potholes in either the trochlear groove, the medial femoral condyle, the lateral femoral condyle, and we'll offer them that. And again, the size matters, because what we want is to have a contained focal defect that we can work on. The subchondroplasty side of things, interesting point you make, because so far most of the patients I've operated on are over 40, and they've got some degenerative change, but they have also got diffuse cartilage loss. So there's no pothole, so to speak. So the use of a nanofracture, in my experience, hasn't been very good. So in those instances, I consider them for subchondroplasty.
Right.
But that's the older age group.
So you're saying in those instances, there's just like a generalized wearing down of the cartilage as opposed to the potholes as such in the younger group. But with the nanofracture, you're saying you can use it on multiple or more than one at least pothole per knee.
I can, and I have.
Right.
Again, these are anecdotes, but I do recall the beauty of endoscopic procedures. You can look throughout the knee.
Yeah.
And if you identify any areas where there's a focal defect, it's not just in the medial femoral condyle. Some patients present with patellofemoral pain, and you find that they've actually got a focal defect. For the trochlear, it's relatively easy. The patella is more difficult, and patella can be quite unforgiving.
Okay. I mean, is it so would you use it on try it on a patella or never go there with patella?
I would, but often it's in conjunction with another procedure. In some of the patients with patellofemoral disorders with a focal defect in the patella, I've combined the nanofracture with what we describe as it's a bit of a mouthful, matrix-induced autologous chondrocyte implantation.
Yeah, or MACI for short. Yeah.
Or MACI for short.
Yeah.
But I just remember MACI in America. There's a MACI in America, isn't there? That's a Y one, MACI. Yeah.
And okay, so that's a great little one to dive into. So, and what's been your results then with the MACIs with patellofemoral problems? Because that's traditionally, like you say, it's from what I've researched in the past. That's always been a trickier area to treat. I think, as you mentioned, so the patellofemoral it's a sliding surface. It's not quite the same as the typical femoral joint. But yeah, what's your experience?
Yeah, I've done 5 and I've had only 3 really satisfied patients.
Okay.
The first one I did, as usual, when you have your first one and they're really delighted, you're very pleased because think that's the right procedure. And that took a long time. The second one, we had to do a mini open, which made the operation even quicker. And he was satisfied. But the 21-year-old and the, I think the 25-year-old, they found it difficult. It was still painful. But in hindsight, it may be because they still had some bone marrow edema.
Okay, brilliant. So, I mean, that's already been a fascinating interview already. So, but let's now get into a little bit in terms of you mentioned earlier on, knee replacement. So, we're then thinking the older age group, obviously 20s, 30s, it's not really appropriate for because they're gonna need another one in their 40s. They're gonna need another one in their 50s. It's just not really a sensible option. I mean, the youngest I've heard of people having knee replacements, I think is perhaps 40s, but and maybe 50s, but it tends to be 60 and older. Is that fair to say? Yeah.
Yep, indeed.
What's your experience? What's your opinion? What's your there's lots of debates in the industry in terms of should you go with robotic surgery? Should you not? What's your take on robotics?
I think robotics surgery has certainly got a place. The procedure does take a bit longer than the conventional knee replacement. I think there's a lot of focus on alignment, but my personal opinion is that when you use robotics, you need training, the staff need training, and it does take a bit longer. But you probably call me a dinosaur, but there are other methods of management, such as patient-specific instrumentation or patient-specific implantation. So bespoke type, if required. For a standard knee replacement, in the hands of somebody over 45, the process is based mainly at looking at alignment, and there are templates now that you can have preoperatively to ensure you get the right alignment and use the right polyethylene thickness to actually enable the patient to have a successful knee replacement.
Does that involve like CT planning and CT kind of pre?
Yes, it often involves CT planning or even X-ray planning. For the majority, is X-ray planning, where you have a software that allows you to really determine what implants to put into the patient. But we don't rely on just that satellite navigation type of treatment if it feels right, because of the number we've done over the years. in my case, over 20 years, you have an idea of the alignment because you see it on the table, and you actually range the knee motion before you close up. And if the balance is right, then the knee will move as it should.
Yeah. Okay. Fascinating. And then another kind of hot topic, let's say, is the, I think you mentioned or touched on it, is things like the custom knees and the bespoke knees. So things you may have heard in the press, we've got the conformist knee, where it's the idea is that they're trying to do they're doing a 3D mapping of your own knee to try and give you a prosthetic knee that is literally contoured and shaped to the size and contours of your original knee. So the idea is trying to feel as natural to the patient as possible. And the debates go between things like the patient satisfaction, number one, but then also how can you rely on it? Because if they've got a faulty biomechanical knee and you're replacing it with a faulty biomechanical, it might feel great, but is it then going to wear out quicker? What's your take on that whole kind of debate? Are you a fan? Are you not a fan?
I'm a fan, and the reason why I'm a fan is it doesn't apply to all patients. I often have patients with malunited fractures of the femur, and what we do for a knee replacement, we use an intramedullary guide. And so we put a metal rod through the femoral canal to give us an idea of the procedure for the cuts and for implanting the knee in a satisfactory or perfect position. I've used conformists. I do like conformists. Conformists, there are other companies. Zimmer does them, Symbios, and Depuis, to name a few. What I like about Symbios is that it looks at the medial and the lateral compartments. So the polyethylene is separate. You've got polyethylene for the medial side, polyethylene for the lateral side, whereas in a lot of the other knee replacements, the single polyethylene. Right. So it takes account the thickness of the polyethylene in each compartment. Oh. And my experience has been quite positive. It's something that I've used in, I think I used in a 41-year-old, only because I was anxious to make sure that we got the balance right. And a conventional knee might have been okay, but I was quite pleased using conformists. My personal opinion is that a lot of the implants that I use can be off the shelf. There are instances where I will use conformists in the young patient, in the patient with patellofemoral malalignment, in the patient with a malunited fracture of the femur. I think what the theatre staff like most about it, from what I've been told, is that it's ergonomic. You can use 2 trays for your operation, whereas a standard knee replacement might need 4 or 5 trays.
So by trays, really you think about plastic or polyethylene?
Oh, I beg your pardon. The instruments that we use for the knee procedure.
Trays, you mean?
Yeah, the actual trays. Yeah. The actual trays for the knee procedure in theatre is confined to about two trays, whereas in the standard knee, it's 4 or 5 trays.
Okay, yeah. Right, excellent. So, am I right in hearing then you're saying then in let's say the younger age groups, the 40s, the 50s, and the more active, then you're tending to go more in favour of those bespoke knees. Is that right? Because of various reasons, it's going to feel better. They're going to feel happy when they're active, and what about things like cruciate sparing? Is that a factor as well?
The conformist that I use is cruciate sparing, the PCL sparing, or what we describe as CR, cruciate retaining. I've used conformist in the younger patients, but really it's often down to the individual. I mean, you'll have a patient who presents, who's read everything about conformist, knows somebody's had a conformist, and would like to have a conformist knee replacement. And there are those who I will give the information regarding conformist and the information about the implant that I particularly like to use, and they have that decision. Sometimes they will ask me, what would I recommend? And I will recommend the standard off the shelf, depending on the patient. But the very active individuals and young individuals, I start to think about bone conservation. One of the advantages of the conformist is that you cut less bone.
Right.
So should they need a revision?
Yeah, thing to revise later on. Is that what you mean?
Yes, that I think that's the idea, really, to try and save as much bone as possible, so that when you do have to revise, there's less, there's enough bone, so to speak, compared with a standard knee replacement.
Got it. Excellent. Is there any information on, again, that's a difficult question. It's going to vary, very massively with, as you said, all different factors. But is there a rough rule of thumb with regards to, if somebody has a successful, whether it be, Conformis or Zimbios, one of the others, but these bespoke knees, is there a rough rule of thumb in terms of how long they might last as compared with the off the shelf? Is it a case that they're going to last not as long, but they're going to be easy to replace, or is there a gauge on that?
That's an excellent question, Rob. I've got someone's giving me a mild headache at the moment, because I introduced him to the ODEP rating, which is the Orthopedic Data Evaluation Panel, and he's an engineer. And what we talked about was based on what evidence there is. Conformis, Zimbios, great implants, but a lot of the off-the-shelf prostheses have 10, 15-year results, which are excellent. And the particular one I use, I don't know if I can mention it, Zimbios, mentioned already, it has 13A rating. And so the higher the number, the higher the longevity. So a 13A rated prosthesis is something that has been around for longer.
Right.
And so in this instance, it is very likely this particular patient will go down the route of the ODEP.
Okay. And what was the name of that one again? You said it. Sorry. Is it what? Which type of?
Next gen. It's actually next gen Zim environment.
Oh, okay.
But what's interesting, Robert, a lot of more patients are actually asking really good questions.
Yeah.
And this engineer, he asked me about the composition, and I welcome it. I think it's fantastic. Yeah. The composition of the implant, the manufacturing of the polyethylene, the comparison between polyethylene that hasn't had vitamin E infused into it, and in his opinion, will he be able to return to activities that he enjoys doing? He likes climbing, he likes cycling. And I said, yes, he can. The first consultation started with him presenting the Conformis. And he'd read an article about somebody who'd, I think they climbed a mountain. I can't remember which mountain. And he was.
We're talking total knee here, not partial. We're talking a total.
This is total knee. Yeah. And he was delighted. So he wanted to find out a bit more about it. And then we went down the route of ODEP rating, and I think he will probably be pushing towards the ODEP rating.
So is that a case that then it's just that there's like you say, they've been around longer, and therefore there's more data? Is that what it is?
There's more indeed, it's more data, and if it hasn't been changed, I think if it's been unchanged, usually that is what they concentrate on.
Okay,
so once it's changed. Sorry, go on.
Yeah, I was going to say. So it sounds like there's a lot of anecdotal, a lot of happy patients out there who have had Conformis and others, and as you say, it's kind of, yes, there's data, but they've had it in the last 5-10 years. It's not like they haven't had the next gen that's been around for umpteen years, and therefore it's not you can't pin your hat as much on it because you don't know where they'll be in 5-10 years time.
Absolutely. But I always want to give them informed choices, so they can know the pros and cons.
That's really good. And then let's we'll have to try and wrap it up soon because we don't want people to get bored watching this video. But not that we'll get bored. I'm sure you're fascinated. It's been fascinating. But in terms of things like patellofemoral joints, so that I think there's often a decision to be made. Even I think I'm right in saying even within total knee replacements, whether the surgeon replaces the kneecap, doesn't replace the kneecap. I guess that comes down to whether there's disease in the kneecap, and obviously if the kneecap's pristine, no reason to change it. But if let's say somebody has got wear and tear in their patella, is that a game changer in terms of having a total knee? Does that then mean they've got less? Their prognosis is not as good, or again, what's your thoughts on that?
Well, Rob, opinion is divided. If you have isolated patellofemoral arthritis, there are surgeons who will look at the patient, and if the patient has end-stage arthritis, that means straight down to bone, and the tibiofemoral compartment is pristine. There is a group that will consider just isolated patellofemoral replacement
Mm.
They'll do other things first, including the non-operative measures. Some will arthroscope the patients, some will inject their knee to see how their response is to the injection to the knee. And then there's a group who perhaps I was in that group until about 6 or 7 years ago, who looked at the literature and found that the patellofemoral joint replacement results were not very good.
Mm.
And it may have been due to design of the implant or a number of factors. And they found that the patellofemoral replacement was actually failing. And in those individuals, surgeons would opt for a total knee replacement. Now, if we're looking at knee preservation, that seems like a no-brainer. You've got somebody with just isolated patellofemoral arthritis. And some studies indicate it's 20% of the population of the knee patients. In my experience is less, certainly in my practice, less than 5% of patients have isolated patellofemoral arthritis. And I have, touch wood, been successful with patellofemoral, I tend to call it resurfacing, because when you replace the patellofemoral joint, you have to be accurate enough to make sure that you haven't pushed the patella outward, increasing the tension on the quads, or that you haven't got a malalignment in which the patella slips off the side. So I tend to go for a patella resurfacing, but it's probably one or two a year for me.
Right. So that is a case of replacing the trochlea, is that right? And then putting a button on the patella, is that right?
Absolutely. And I tend to like to call it resurfacing. So I use an implant that sits in a crater that we've created in the femur, in a trochlea, and then a button. So it means that the forces across the knee hopefully haven't been changed. And in those instances also we look at the alignment, because if they've got isolated patellofemoral arthritis, there may be a malalignment. What I mean by it is that the patella might be translated laterally, increase the forcing across the knee, and that would have to be addressed too.
So as far as that patellofemoral articulation goes, though, and say in an isolated patellofemoral resurfacing as you just described, is that pretty much the same thing as you're doing in a total knee, or does that differ in a total knee?
It differs in a total knee because the femoral component is quite a large component, so it covers the trochlea too. And there are mixed papers on whether to resurface patella or not. And the conclusion, certainly in my experience, is based on the implant. This implant that I prefer to use, even if they have degenerative change in the patella, they can manage without resurfacing of the patella.
Right. Wow. Okay. Interesting stuff. And if then they had to let's say they had that resurfacing, but then some years down the line they then had to come back to you and go for a total knee or partial knee, is that an easy job to do, or does that?
Yeah, in my hand, it's an easy job to do because of course you've saved bone. And the indication for the revision. We don't take revisions lightly because often there's a number of causes of this and patient expectation. I mean, I remember years ago, patients telling me that I've come to see you a second opinion because I was told I'd be, walking up, I don't know, the Kilimanjaro at a year after my knee replacement, and it's 6 months and I've got a plan on what I want to do and I'm still in pain. And then their jaw drops when I say it takes up to 2 years to recover from a knee replacement. Some will either say, well, no, I thought it's for old people, or some would say, well, no, I think I'll be fine. And then they find that it's not just the knee itself, the soft tissue, or the activities that they do. So I say to them in 2 years.
Wow. Okay, that's good for people to know then. Yeah, so it's a quite a big deal.
Yeah,
as you say. Where do you see the future going with these sorts of things, Howard? In terms of, do you think there'll be, does the future hold in terms of less bearing surfaces and different, like say even better? I know there's newer grades of polyethylene now. You mentioned the vitamin E infused polyethylene, but do you think other materials will come in terms of going from metal towards ceramics or even pyrocarbons, or is there a direction that things are heading in with regards to that?
The direction is yeah, they're looking at the bearing surface at the moment is highly cross-linked polyethylene with vitamin E to reduce the free radicals that degenerate the polyethylene. Some have looked at ceramic, but I think they've looked at it from the allergy point of view, because a number of patients have been found to be nickel allergic.
Okay.
I have no experience of use of the ceramic or the oxinium, which is one of the companies uses a layer of ceramic. I think the direction that it will take, it's going to be based on either using 3D planning and 3D printer for individual implants, but still using the same type of metal implants with a polyethylene liner. And I suppose what we would be aiming for is to try and delay the need for a knee replacements as the end stage of treatment of knee arthritis. So maintaining the joint as long as possible, supporting the tissues, looking outside the knee and the hip to try and actually improve the individual, and looking at lifestyle. It's incredible that it's only it's probably been around for so long, but in the last 10 years, people are really looking at lifestyle, looking at, I think somebody called it dietary inflammatory load.
Right.
Don't worry, I don't understand that either. But they're looking at the dietary index to see if the constitution of an individual's diet predisposes them to osteoarthritis. Because at medical school, what we learned about was mainly injury and patients with cartilage problems. But looking at lifestyle, looking at diet is becoming such a big thing now.
Yeah, big hot topic. And I mean, one of the things I think read relatively recent last few years is there's a fascinating piece of research that showed something like, even just in simple terms, things like, just looking at your BMI, your body mass index, and if people lost something like 10% of their body weight, it often then led to a 50% reduction in their knee pain.
Yeah,
that might be exact figures, but it was something like that, and as you say, just how big a factor the biomechanics, their overactivity and lifestyle can be. So yeah.
And I've had an interesting, Rob, sorry to interrupt, I've had anecdotes when the lockdown was eased and good coronavirus, and we had telephone consultations, and you'd ask patients, well, how have you been during the lockdown, and how's your knee? And some would say, oh, you won't believe it, doctor. I've been doing exercises, I've been following XYZ on YouTube, and I've lost weight. And I feel that my knee's better. So I don't want anything. Thank you very much. Goodbye. On the other hand, of course, I've had I think, is it a couch to 5K run?
Yeah.
It's usually men, unfortunately. We men, so we get off the couch and start exercising. But those are usually, meniscal injuries.
Yeah. We've seen a few lockdown injuries as well but no, you say there's pros and cons, isn't there? So, but no, that's interesting. Very, very interesting. Well, Harold, that's really, really fascinating. Great talking to you as always. And
you too,
thanks for your time today. And I hope everybody who's watching this video found that really as interesting as I did. And we'll talk again, perhaps about another topic.
Marvelous, indeed. Stay safe.
Thanks again. Take care.
Thank you. Bye.
Right.